10-minute topic on complications of diabetes. One of the clinical and theory objectives of Nursing 284 is to differentiate the pathophysiology, clinical manifestations, and management of persons with diabetic ketoacidosis from persons with hyperglycemic hyperosmolar non-ketotic coma. So let's start with DKA, diabetic ketoacidosis. It is a serious complication of diabetes that can result in coma or even death. Because there is no insulin, the body uses fat for fuel instead of glucose. And the ketones are a waste product of that fat breakdown. And these ketones build up in the blood, and their production exceeds their excretion. When we talk about the symptoms of DKA, we see frequent urination leading to increased thirst and severe dehydration. The patient will complain of flu-like symptoms, nausea, vomiting, abdominal pain. This is where we're going to see the Kussmaul's breathing, which is hyperventilation with that fruity, smelly breath. And they will have an altered mental status, which could be obtunded or just mild confusion that is progressive. Diagnosis of DKA, well, we will see a blood sugar of greater than 250 milligrams per deciliter. The urine will be positive for ketones, as will the blood, and ketones in the blood is registered as acetones. So our patient becomes acidotic. They have a pH of less than 7.3. Their serum bicarb is less than 18, and they have a low CO2 in their blood, so they have metabolic acidosis. How do we treat this? Well, we're going to stabilize the individual. Our ABCs first, always airway, breathing, circulation. We're going to make sure we stabilize blood pressure, pulse, and respirations. We're going to rehydrate them. We'll start out with normal saline, and then we switch over to D5 when their blood sugar is less than 250 milligrams per deciliter. We want to correct their acidotic state and their electrolyte imbalances. Potassium becomes extracellular. It jumps out of the cell with hyperglycemia, and that can lead to increased plasma. Well, it does lead to increased plasma potassium at first, and then as the body excretes potassium and as the hyperglycemia improves and is corrected, the potassium jumps back into the cells. It becomes intracellular, and that can lead to a very low potassium. So we have a very high to begin with and then very low, and that can happen quite quickly. We're also going to look at phosphorus, calcium, and magnesium and make corrections, correct those electrolytes as needed. We're going to start an IV insulin bolus and then an insulin drip on these individuals, and follow their blood sugars very closely. And our goal is to get the glucose between 50 and 75 milligrams per deciliter per hour. So we're probably going to be doing hourly sugars and even closer than that if need be. We're going to be monitoring their urine output, their electrolytes, ABGs. We want to watch the correction. Primarily, we're looking at potassium because it can jump in and out of the cell so quickly and have such a drastic effect. We're going to consider changing to subcutaneous insulin as soon as we have a stabilized sugar, and we will treat the cause of the DKA and also educate our patient as to where they could have warded this off. So what is the cause of DKA? Well, an illness or infection. Often if a patient has pneumonia, pancreatitis, sepsis, and has diabetes, they could get themselves into trouble. Sometimes newly diagnosed diabetics, and they are unfamiliar with regulating their sugars with insulin, will fall into this situation of DKA. Maybe they're not taking insulin and they need start to the point where they need to have insulin. Recent MI, CVA, trauma, surgery, stress, medications like steroids will cause DKA to occur. So how do we prevent it? Well, patient education is number one. We need to educate our patients. This is why we have diabetic educators. This is why we learn so much about diabetes, and we need to continually be educating our patients. we need to make sure they understand sick day management. And I know you've gone over this before, but this also includes monitoring their ketones when they're ill, or if they have a consistently higher than 300 sugar, they are at higher risk for DKA. Staff education is most important. We want to make sure that everyone knows that our type 1 diabetics need to be on basal insulin even if they are NPO. Okay, so that other state that I talked about it in the beginning, hyperosmolar, hyperglycemic, non-ketotic syndrome, or HHNK/HAS, often you'll hear it just referred to as HHNK. It's another serious condition of severe hyperglycemia, which can also lead to coma or death, and it has a 15% mortality rate. There is insulin production, but it's inadequate, and a smaller amount of fat is broken down per minute, decreasing the buildup of ketones, and the body has a chance to eliminate ketones as it's produced. So, in our symptoms of HHNK-HHS, we see increased urination leading to severe thirst and extreme dehydration. Ketones in the urine is either undetectable or very, very small, also in the blood, and remember it's called acetone in the blood, and therefore we won't see hyperventilation and fruity breath. We won't see the Kussmaul's breathing in this situation. Their serum bicarb and CO2 is normal, and the sugar seems to go higher just prior to them getting into trouble. The sugar usually is greater than 600 milligrams per deciliter, and it can go as high as 1,500. Serum osmolality is greater than 320 in the blood, and it's very concentrated. There is very poor skin turgor, very dry mucous membranes. The patient could be tachycardia, they're drowsy, lethargic, coma-like. So how do we treat this? Well, we're going to stabilize the ABCs once again. Blood pressure, pulse, respirations. We're going to get a handle on that. We're going to rehydrate with normal saline to begin with, then switch to D5/2. And if we have a patient who has a history of heart failure, like many of our elderly do, we want to be very careful with this fluid resuscitation that we're doing. Not only with the elderly, but anyone that has a cardiac history is at risk. We're going to use IV insulin by bolus, and then a drip is started. Our goal is to decrease the glucose by 50 to 75 milligrams per deciliter per hour. We're going to be monitoring that very closely. And we are going to convert from that IV insulin to sub-Q as soon as the patient is eating, and we can get that sugar to be less than 200. Because of the electrolyte imbalances, we're going to be looking at the potassium very closely. It will start out very high but drop rapidly as it returns into the cells, so we need to keep an eye on that. Once again, patient education is most important for our patients, going over sick day management and talking to our staff. What are the causes of HHNK? Exactly the same thing as I talked about for DKA. So the similarities between these two situations, between DKA and HHNK-HHS, is that they are very high risk for coma and possibly death. They are both treated with IV insulin, and we're going to see increased urination, which leads to a severe dehydration. Therefore, they both need aggressive fluid resuscitation. They need aggressive hydration. Potassium, magnesium, phosphorus, we need to look at those electrolytes very closely and manage them. And the differences between these two, let's look at DKA to begin with. In DKA, we see ketone or acetone positive in the urine and the blood. So we see positive ketones in the urine, positive acetone in the blood. We have a low pH. We have the blood is acidic. We have a decreased bicarb and CO2, which is in an attempt to compensate that. So this is a compensated metabolic acidosis. We see it mostly in type 1 diabetes, DKA type 1. It has a much more rapid onset than the other, and this is where we see the Kussmaul's breathings, which is the hyperventilation with the fruity breath. On the other hand, if we look at Hhnk, HHS, what's different about it is the acetone in the blood is undetectable or very small, and the ketones in the urine is very small or undetectable. Their pH remains normal, therefore both the bicarb and the CO2 is normal as well. We mostly see this in type 2 diabetics, and it has a much more gradual onset than DKA, and the respirations can be fast, but they're not fruity smelling. So those are our differences.